All right, we'll go ahead and get started. Thanks everyone for joining us today. Very happy to have you here. My name is Terrence Henry and I'm the Executive Director of TAMEST. That stands for the Academy of Medicine, Engineering, and Science of Texas. Really glad all of you could join us today for this session on survival and recovery from COVID-19. Before we get started, I'm just going to say a few brief words about our organization and then tell you a little bit about the format for our session today, and then I'll turn it over to our moderator. The Academy of Medicine, Engineering, and Science of Texas supports collaboration to advance research, innovation, human talent development, and business in Texas. We are composed of more than 300 members in Texas of the three national academies. So the National Academy of Medicine, National Academy of Engineering, National Academy of Sciences, as well as our 11 Nobel laureates in the state of Texas. We are supported by our 18 academic member institutions, 3 of which we have represented here today with UT Southwestern, Houston Methodist, and UT Health San Antonio. We're very grateful for their ongoing contributions and support of our organization, as well as the founders of our endowment, to help us convene our research community and contribute to the health and vitality of our state. So since the beginning of this pandemic, TAMEST, we've been convening scientific experts from across Texas and across the country to really share the scientific knowledge that we have so far on this virus and this disease and pandemic, and also to kind of map a path forward for our state and our nation through this pandemic. So today's session, we're going to really focus on what it's like to survive and recover from COVID-19, including some of the chronic impacts that many are experiencing as a result of the disease. We want to take a moment and thank our presenting sponsor for today's session, which is Lyda Hill Philanthropies. Lyda Hill Philanthropies is committed to funding transformational advances in science and nature, empowering nonprofit organizations, and improving the Texas and Colorado communities. Thank you for your support for this very important session. So today will be a 1-hour session. We have 3 speakers in addition to our moderator. Each of them will have 7 minutes for their presentation. And then after all the speaker presentations have concluded, we'll have Q&A at the end of the session. The best way for you to submit your questions is through the Q&A box in the Zoom window. And some of our speakers, if they have time during the presentations, may type answers to some of your questions as well. I'm now very happy to introduce our moderator for today's session, who is herself a survivor of COVID-19, who will share her story with us. Dr. Claire Aldridge is Associate Vice President of Commercialization and Business Development at UT Southwestern Medical Center. And Dr. Aldridge is so near and dear to TAMEST because she helped us put together our very successful conference back when we were having conferences earlier this year in January. So please join me in welcoming Dr. Aldridge, and I'll turn it over to you. Thank you very much.
Thank you, Terrence, and thank you so much for inviting me to moderate this panel. I'm so excited about it. Again, as Terrence mentions, I am a COVID survivor. In March of this year, we went to spring break to New York City to see a few musicals because our daughter is kind of musical crazy. And we went there on March 11th. And if you go back and look at your calendars of what happened on March 11th, while we were in the air, the WHO declared it a global pandemic and the NBA basketball season was canceled. So the world we landed into was very different than the world we left from Dallas early that morning. And so after we returned, we only stayed for about 36 hours because it became very obvious that things were very different, and Broadway was closed the day after we got there. We came home, we quarantined appropriately, and after about 4 or 5 days, we started having some symptoms, and I was able to get tested through my relationship with UT Southwestern when the drive-through clinic opened, and was by then not surprised to get a positive result. But interestingly, our experience was very different than what was in the news at the time, and actually had a $20 bet with my husband that I did have COVID and he felt certain we didn't, because we didn't have any of the symptoms that were being discussed at the time. We never ran a fever. We never had shortness of breath. We never had a sore throat. Instead, we lost our sense of smell and taste. We had horrible body aches and headaches, but really other than that, in the lethargy, it was a very different experience for us. And now we know more about it and know that that was a relatively traditional experience for the less severe patients. But as in my role heading up commercialization at UT Southwestern, had an opportunity to really be able to see what our faculty members and our clinicians are doing on the front lines. And I'm so excited to talk to the folks we've got today and learn about what's happening in the clinical care, both acutely and in the long term for the patients that are getting COVID and surviving, and what we can do best to support our community. Our first speaker is going to be Dr. Mark Boom. He's the President and Chief Executive Officer of Houston Methodist, and also the Ella Fondren and Josie Roberts Presidential Distinguished Centennial Chair. And he's going to be talking a little bit about the world that he's seeing at Houston Methodist with regard to COVID and survivorship.
Well, thank you very much. Welcome everybody, and thank you for sharing your story. I will tell you, we were due with our daughter, who is also a big Broadway type fan. We were going to head to London a couple days after you were headed out and see a bunch of shows, and managed to cancel right at the last minute. So avoided that, and I'm glad you're feeling much better. Let me talk about Houston Methodist, some of the activities we've been doing here, and tie those to really the topic of the day. If you'll move to the first slide, just to give everybody a little context of our experience. Houston Methodist is a 8-hospital system, 1 long-term acute care hospital, so 7 acute care hospitals, flagship hospital in the Texas Medical Center with 1,000 beds, and then 6 community hospitals. And actually, interestingly, the LTAC, we took part of the work we had done during Ebola and turned some units into what we call a HIDU, a highly infectious disease unit. We had done that during Ebola and then scaled that up. So we at one point had over 63 beds available there as well for COVID. This is our curve of experience. So in the blue line, you see the number of patients that we had in a bed at any given time at Houston Methodist. And, I remember all the big shutdown in March and April and everything else that happened. And, what seemed like a big, terrible ordeal at the time. We thought it was a big mountain we were climbing. As I tell people, I think we realized later we were just in the foothills, and, had this big, massive surge, as everybody knows, in most of Texas, the latter part of June, with Houston kind of leading the way, both timing wise, as well as ultimately probably, size of the spike wise outside of the valley, which was really probably the worst and hardest hit area in all of Texas. And then you can see, where we've come to today. It's interesting. We're all celebrating right now what's starting to feel a little bit like a plateau. I'm hoping it has some more to come down. And our plateau is basically the first peak. So I'm hoping we can get this thing down a lot. But we got as high as 750 beds in the middle of the day with a known positive, let alone another 100 or so in workup at any given time. So we're using 850 beds for patients at Houston Methodist. So a much better time now, but it has been quite challenging. And we've gained a whole heck of a lot of experience during that time. So if you'll move to the next slide, I want to share a couple of those pieces of experience. And I'll talk about the database that we've put together to support our work and support a lot of work going in the future. And this is one of those outcomes as a result of this. This was published in the Journal of the American Medical Association a couple of weeks back, and really taking a look at what we defined as the first surge through May 15th. And then, we were in that's kind of the middle of the lull period, or the plateau period, where we were probably around 100 patients at that point in time. And then arbitrarily kind of cutting off at mid-May, and then really, capturing much of the surge, although the peak really happened right about 7/3/7/4. So there's probably another paper to come on did things shift afterwards. It was very interesting what we saw, and you were seeing this around the country, and that people were reporting that this next surge somehow was not as bad as the first surge from a mortality standpoint, from an ICU utilization standpoint. And I think there were some distinct reasons for that. No question, some of the treatment side of things did play into that. Perhaps some of the, vulnerable population, getting hit first may have played a role in that. But a lot of that had to do with age age, and comorbidities. So what we saw, and you can see in the right, all of these were highly statistically significant. A modest but highly statistically significant decrease in average age. Lower than 50-year-olds went from about 1 in 4 to over 1 in 3. So, you know, a meaningful difference and a statistically significant difference. On the comorbidity side, what we saw then was, you know, very significantly less, although lots and lots of people with diabetes, hypertension, morbid obesity, or obesity even at the 30 level, let alone then obviously even higher levels of morbid obesity. Still very meaningful. You still see 25%, and up in each of those statistics, but significantly lower. And so I think a large part of the mortality decrease we saw, the less ICU utilization, the shorter lengths of stay, there was certainly a significant element to that. What you're going to see as we start to look at data after this, I don't have that here because we're still analyzing it, is the pendulum swung back. So I take that as, you know, we protected sort of the more vulnerable were more careful. The less, you know, vulnerable or perceived less vulnerable went out, let their guards down. We ended up with a big surge and then began to infect those others. And so we saw mortality kind of come back up. We saw some of those age things come back up after that. The other thing which has been heavily reported has been that we saw socioeconomic differences really heighten, particularly in the second wave. From a percentage basis, on a racial basis, we did not see a significant difference in whites and blacks. We did see, from an ethnicity standpoint, a dramatic increase in the Hispanic Latinx population, and you can see those percentages here. We also saw across the board a decrease in, it's not here, but a decrease in zip code median income, and then you see the self-pay statistics here as well. So you can see very significant changes. If you look at the next slide, this is another set of work that we've done. We were the first hospital in the country to utilize convalescent plasma right at the end of March. I think we beat Mount Sinai by about 24 hours. It's always nice as a Houstonian to beat New York. And I'm sure other Texans on the call share that. My apologies to any non-Texans here, but all in the same common good. And we have done a great deal of work on this at Houston Methodist. Now, we've released one of the key papers in the American Journal of Pathology here. This is a paired analysis, so this is not a randomized controlled trial. Interestingly, because I know there's obviously been a lot of debate about that, our IRB actually turned down our investigators early on an RCT for a couple of reasons, one of which was a concern about taking, because it was really obviously in a more critically ill population, large volume, ultimately sham kind of infusions, not to mention that this was a therapy that was, had been used for well over 100 years. So they actually, we didn't do one here because our IRB was not comfortable with it. So we've done all these patients. This is the case matched series, and you can see in the upper left, I don't have the groups defined, but I'll explain them here. Group A is everybody. And so you can see not statistically significant, some signal, but the p-value was 0.13. So, not even remotely near statistically significant. You could look at a couple subgroups in B and C. I'm not going to delve into those, but D was the ultimate subgroup where we saw strong signal. So B was everybody who got infused early in the first 72 days. And you can see there some signal and a P of 0.09. But when we looked at people who received high titer and were transfused in the first 72 hours, pretty high, statistically significant, 0.047, but pretty significant difference in mortality there. So some pretty strong signal, but just signal, obviously, not an RCT at this point, but highly consistent with the 35,000 plus patient series reported through the Mayo Clinic across the country, as well as highly consistent with some that came out of Mount Sinai as well. We are actually glad that this is going on. We don't see an RCT and the use under an EUA as mutually exclusive, and this enables us to continue to use this for further patients. And then to wrap things up pretty quickly here, I alluded to this, but we have created what we call Curator, which is our surveillance and outcomes registry. We've now tested over 116,000 people, 17,000 plus have been positive. just going on 6,000 admitted to our hospitals. So it's a very robust database. This team here from our Center for Outcomes Research, at the bottom right, you see Dr. Beta Cash, who is a kind of co-employee of ours in Texas A&M. So great partnership with our friends, colleagues, and partners at Texas A&M University. And then finally, if you look at the last slide, we are very actively putting together a multidisciplinary approach to the long haul patient, to the patients who need ongoing care. You can see on the left, and I know we'll be talking more about this, all of the different manifestations of this disease. We've got a clinic being built, including internal medicine, pulmonary, ID, rheumatology, GI, nephrology, neurology, cardiology, psychiatry, PM&R, really a very multifunctional, multidisciplinary team that is being structured to care for what we anticipate will be a large number of people who need longitudinal care. Thank you very much. I'll turn things over.
Wow, thank you, Dr. Boom. That's amazing how much is going on in Houston, and I think I didn't really appreciate the numbers that your hospital system was seeing. That's a remarkable way that you just stepped up and provided care. Our next speaker is Dr. Alka Gupta from the Weill Cornell School of Medicine. She's the medical director of the Integrative Health and Wellbeing Clinic, and really working very diligently on the COVID recovery and what we need to do to support these folks. So Dr. Gupta, I'm looking forward to hearing from you.
Thank you. Thank you so much, Dr. Aldridge. And hi, everyone. Thanks for inviting me to take part in this conversation today. I have to say I'm really excited to be joining you from New York City and to learn from all of these other fantastic panelists. I think in these few minutes, I will share my experience creating our recovery unit. And as you know, things in New York City escalated quickly and early. So once our patients began recovering after weeks, sometimes more than a month of hospitalization, we really started to see what we considered our next peak. High numbers of patients with high morbidity post-COVID-19 illness. Many had profound weakness, many had peripheral neuropathies, cognitive effects, and early on, rehabilitation options were limited in terms of number and also in terms of capacity. So we had to figure out how to care for our own. And so we created a recovery unit. When thinking about how to structure the unit, we had just what we knew at that time. We knew that patients with post-ICU syndrome, for example, often have high rates of depression, anxiety, PTSD, and studies suggest that about half of patients after a critical illness might not be back at work even a year after discharge. So we assumed that our patients who are critically ill due to COVID-19 would suffer from the same downstream consequences, plus additional effects of the trauma, the uncertainty, and the extreme isolation that these patients were experiencing. Our objective was to consolidate the recovery process. So rather than the linear method that we're used to, where we take care of the medical issues of a person and then we send them elsewhere for rehabilitation, we needed to be able to provide both the acute medical care and the rehabilitation at the same time. Next slide, please. So our next step was identifying patients who would benefit from this unit. We brought patients from medical floors and from ICUs. These were patients who were medically stable enough to tolerate at least 30 minutes of physical therapy and occupational therapy each a day, and also able to interact with staff and other patients. There were individuals who we thought would require at least another week of inpatient level of care, and patients that we thought would either be discharged home from our unit or to acute or subacute rehab. On the next slide, you'll see our staffing model. We assembled a care team to basically create a hybrid med rehab unit. The medical team was led by a hospitalist, our rehabilitative team led by a physiatrist, and we had 10 to 12 physical therapy and occupational therapy staff who shared coverage of the unit, which allowed for some continuity and for patients to work with the same team day after day. We also created a core consultative team of specialists that we thought patients would need more attention from, including a neurologist, a neuropsychologist, and a psychiatrist. We can go to the next slide, please. We actually created this unit in our inpatient psychiatric unit. We built out one conference space as a gym with practice stairs, an exercise mat, stationary bike. We had weights and we had cognitive games. And we had a second conference room that we used for staff huddles and rounds, and in the afternoon was used for patient-facing programming. We tried to help patients reintegrate socially and get used to reality again, because we were seeing people who had been hospitalized, never seeing a person's face other than their eyes for 4, 6, sometimes 8 weeks. We created a daily predictable schedule that we gave to patients that had physical therapy times, occupational therapy times, meal times, diagnostic tests that needed to get done that day. We provided behavioral therapy at individual levels and group levels, really aiming to identify anything that would require further attention on follow-up. We had additional structured virtual offerings, things like chair yoga, mindfulness, meditation. We provided individual tablets with music, meditation, and other web-based resources that patients could also use on their own. And then we also had some occasional unstructured socialization opportunities. We had a shared mealtime in a common room. We had a physician who was also hospitalized with COVID come in to speak to patients so they could see what recovery might look like a few weeks later, who came in several times. And we also actually had virtual reality headsets for use, which both staff and patients really enjoyed. A lot of people described those moments as an escape. It was important to provide daily updates for families if patients were not able to effectively communicate that on their own. And we had rolling tablets for providers, so we could do rounds where families could be involved and hear and see the care plan, which really heightened the comfort level of all. Having a team-based structure for clinicians was really critical because we had large teams of people who had never worked together. So we had nurses who were traveling from all over the country who were there, you know, on day one. We had many therapists who didn't typically work with us and were often outpatient therapists. And our hospital medicine rehabilitative teams, they often work in tandem, but we usually don't co-manage patients. So it was a new thing for every team. So in the mornings, we had quick huddles that were really rehab focused to identify and prioritize patients to be treated that day. And then we also had more comprehensive interdisciplinary rounds with key members of the care team daily, which was really an in-depth discussion about new transfers in, anticipated discharges, and any needs between the point at which they leave our door and the point at which they see either one of our outpatient providers or their own primary care and specialist teams. We'll go to the last slide. I think I and the team felt really privileged to be able to see and care for patients both in the acute illness, but also in the more uplifting and the recovery process. We tried to share positive updates with the teams who had cared for patients earlier in the stay too, because it was difficult for clinicians to be kind of in the throes of things, seeing critically ill patients day after day. So we would share verbal updates and also videos of discharges when patients consented to that. And I saw a lot of colleagues, both on our team and also on other medical teams, really find that rewarding. It did garner some amount of media attention during the summer because I think a lot of people were looking for hope. And in total, we discharged 106 patients from the recovery unit. About 60% of those were discharged home with some type of home services. About 12% returned to the medical floor for acute issues. 11% were discharged home without any home care or home services needed, and then we discharged smaller numbers home to rehabilitation facilities, shelters, and group homes. And in late July, we discharged the last patient from our recovery unit, and we hope to not reopen it. Thank you.
That sounds amazing. And I think, to be frank, some of those things we're all going to need to re-enter society when we all leave our homes and have to go back to interacting with people on a daily basis again. I could probably use some chair yoga when I have to start doing that again. Our next speaker is Dr. Monica Verduzco Gutierrez, and she's the chairwoman of the Department of Physical Medicine and Rehabilitation at UT Health San Antonio. And I'm looking forward to learning what she has to share with us. Dr. Gutierrez?
Hi, thank you very much for having me here today. So I'm going to be mostly focusing on now what we're seeing long-term after COVID. So again, you've heard a little bit about what did it look like, what were the surge, what happened when patients were hospitalized. And then now we have these patients that are being called long haulers or having long COVID symptoms. And a lot of these patients that I'm seeing, they are not patients who were hospitalized. So the first, of course, we had spikes in Wuhan, and then there was a spike in northern Italy. And so the first papers that are coming of long hauler patients are coming from Italy. So in this study that came out in JAMA, they had looked at persistent symptoms in patients after having COVID-19. And this was, again, mid-50s age, so the same thing we're seeing here. And then not all of them were hospitalized. Maybe they were hospitalized for 2 weeks, and only 5% were intubated. So these were not the most severe patients where you expect to have the post-ICU syndrome. These are a lot of the patients who had maybe pneumonia, even some did not, and they looked at them 2 months later. So if you go to the next, click again, it'll show the picture of what they found 60 days later. And still, of these patients, about 87% were still having symptoms. Only 12.6 were not having symptoms. And so they kind of looked at what were their acute symptoms and what were they having afterwards, with the most common being fatigue, which was almost 50% of patients, dyspnea, and joint pain were some of the top things that they were having. And it wasn't a huge study. They have now a study that came out of northern Italy just recently in the last couple of days, now that it's been 6 months time from there, and seeing what patients are still having symptoms, even though it's been 6 months. And if we move on to the next slide, a lot of these, or they're calling it long COVID. So a lot of these long hauler patients, they've gathered in communities online, since that's what we have to do in this era of social distancing. We have to get on social media and find other support systems. So in this study that came out of the University of Indiana, they went into a long hauler Facebook group and got about 1,500 survivors of COVID to see what kind of symptoms they were having. And you see there's like 50 most common symptoms that they had, with 100% still having fatigue at this point. And again, these were people from different parts of the country here in the US, and also different times since they had had COVID. But fatigue, muscle or body aches, shortness of breath, difficulty concentrating or focusing, inability to exercise, headache. So a major component still of pains, whether that be headaches, joint pains, numbness, tingling, they couldn't sleep, they're fatigued, body aches, as you see these things still going on. And also, it doesn't have there, but some others, what we're seeing is issues with cardiac symptoms. So now American College of Cardiology, as well as the Sports Medicine Society, has come out and said, we are going to give recommendations on screening for patients that are athletes who are getting back to athletics, to if they've had COVID and if it was symptomatic or not. Well, we're looking at these patients and saying, this is not just for athletes, but this is also for patients who have survived COVID and are having some of this still shortness of breath, inability to exercise. They may be having myocarditis as well. So there's high levels of cardiac issues too. And we can go to the next slide. and see. So here in San Antonio and other places, because they had this in New York, I talked to my physiatry friends in New York because they went through it first before we went through it here. And so we started putting together an outpatient post-COVID-19 recovery clinic. And this is also something with UT Southwestern, their Department of PM&R is doing as well. And we kind of got together and said, what metrics are you following? We're doing systematic assessments of patients. We're kind of following certain things on different patients and looking at how they've been affected by COVID-19, how it's affecting their function, how it's affecting their quality of life. Part of our team, it's multidisciplinary. So again, PM&R physicians, we're working with PT, OT, speech, but not just even that. It goes beyond, you know, depending on the patient's need. Do they need to see a pulmonologist? Do they need to see a cardiologist? Do they need to go back to ID? Do they have to just, you know, are they really debilitated and they need pulmonary function tests and pulmonary rehab and they get that program? Are they having, well, we're seeing a lot of dysautonomia or POTS, so or an orthostasis that they're having afterwards, and do they need an exercise program that's pool-based? And then mental health is something major that we're seeing as well. And it's not just for the patients that were in the hospital. So again, it's terrible if you're in the hospital and you're isolated and you didn't get as much face-to-face time and you're worried about your family, but also these patients that were at home, they were just kind of worried, what's going to happen to me? Am I going to get as bad as what I've seen on TV? Am I going to die? And they go to the emergency room or to urgent cares, and they, you know, their SATs are checked, and it's like, well, your SATs are not bad enough to get you in the hospital, so you can just go home. And then they go home and they just get more anxious about the symptoms that they're having. So again, even for patients who were never hospitalized, we're seeing a lot of ongoing symptoms, and then mental health issues as well. And that's part of when we're looking at patients, how we're systematically assessing them. We're doing screens like PHQ-2, GAD-7, those look at depression, anxiety. We're looking at civilian PTSD scores because some of them are having PTSD from having these symptoms and being at home, and also quality of life scales. We're doing a lot of our assessments via telemedicine, because a lot of it can be done that way, and then giving them in-person consultations kind of depending on what their needs are. Again, pulmonary, cognitive, neurological, musculoskeletal pain, and sending them other ways as they need. Next slide. And so this is something that I tweeted that was very popular the other day about the patients that I'm seeing that have long COVID, and everyone's different. No one's the same. I mean, some symptoms here or there, but you really have to listen to stories and to hear what they've been through, because people want to know that, yes, they went through this, these symptoms, they're not making them up. They're, you know, one confusing thing they have is that, well, I was positive in July, but I'm still having symptoms, and I had another test and I'm negative. So why am I still having symptoms? And, you know, I say the symptoms are still real. They're still going on. You may have now be testing negative, but that does not mean that the effects are not still wreaking havoc on your body. And so there's also, again, looking for the psychosocial stressors. You know, they may have lost their job because of this. They're not making any money that they didn't before. And then there's just a large relief when you say, you know, we can help you. There is options for recovery, and this is what we're going to do for you. Next slide is, so these are some of the diagnoses that we've seen, and some are very serious. So, you know, we saw patients in the acute stage. They had a stroke related to COVID and they needed inpatient rehab, and now they're having long-term sequelae. Again, they're having numbness, tingling that they didn't have before. They may just be conditioned, a lot more wounds that we're seeing. And then, you know, it's the whole, okay, we saw them in the acute care, they may need inpatient rehab or subacute rehab, and then they're at home. And so just so many different diagnoses that can be treated for with multidisciplinary teams. And let's see, is there another slide? Or So the take-home message is that so many different presentations, everyone's different. We're going to need a big team approach. Another little take-home message, that part of me wanting to do this was knowing that, so PM&R was a specialty that came out of another pandemic, which was the polio pandemic. Especially the Southwest United States was affected, and we had some of the first major polio hospitals in Texas, which then later became rehabilitation hospitals, and this specialty came about. So now with another pandemic, here we are, available to take care of patients as well.
Thank you so much. That was really interesting, and gave me some more things to lay awake at night thinking about. I will say that was one of the, while I was sick, that was one of the hardest things, was all of the unknown. I think this is something that, I think all of you touched on, kind of the mental health components of this, and that uncertainty and not understanding what the course of this disease is going to be is something that really is nerve-wracking. We have a question from an attendee, and Dr. Gupta has agreed to answer that question. What was the biggest surprise you encountered when dealing with COVID-19 recovery? And after Dr. Gupta, I'd love to hear actually from all three of our panelists.
Absolutely. I mean, to pick one is difficult. I think really the biggest surprise for me is what Dr. Gutierrez was just explaining, just how heterogeneous the downstream consequences are, and how each person's individual experience is totally different. And if we don't validate those things as clinicians or even just as members of the community, then that can actually lead to additional problems. So it's really reassuring and great to hear that that information is more widely available. One thing that we tended to see a lot of in the recovery unit were a lot of neuropathies. And interesting, like there are some peripheral neuropathies that you would expect, like entrapment neuropathies. If somebody is dependent on a certain area for a long time, you would expect to have some downstream consequences there. But we've actually been seeing some less well explained causes of neuropathies. And we'll be publishing a small case series on that soon. And some of these are truly idiopathic in nature. We don't know if that's viral related or due to something else, which I think is interesting. And if I could just mention something on the softer side too, I think the strength and the resilience of family members during this, of hospitalized patients, was really something that was surprising to me. It required a lot of patience and acceptance, I think, to say, hey, I'm not going to see my family member for 2 months, and I'm going to entrust, somebody else with that person's care. So I was really astounded by the resilience of the community here in the city.
That's wonderful to know. I think that's one of the things we're all experiencing, is how important our communities are during this. Dr. Boom, what was surprising to you?
I'd echo some of that. This is one of the things we still don't understand, is why this is so widely variable in its symptomatology, on the acute side. Obviously, people from completely asymptomatic to melting away before our eyes in the hospital sometimes. And we're seeing the same thing now on the back end. Great heterogeneity, and not necessarily linking to the front end. In other words, yes, of course, there are the long haulers who were in-house a long time and have many of the sequelae that anybody else who was in the hospital for 2 months at a time might have. But then there are people who were in the hospital and end up having real problems, people in the hospital who have no problems, and people outpatient, both of those scenarios as well. And we can't really explain that. So that's been quite interesting. I think we were prepared to some extent from the limited experience with SARS, that there are some long-term sequelae. Vascular sequelae have been a big issue with those. We're seeing, clearly a lot of the things we're talking about here have a vascular tie together. But even so, I think nobody was really quite prepared for the breadth and depth. And the last thing I'll say is, many times our clinicians are saying, we're looking at people and we can't tie the objective sorts of criteria with some of the subjective. So I was talking to a pulmonologist yesterday, talking about the number of patients he's seeing with long-term dyspnea on exertion, where he can't necessarily find PFT abnormalities, can't necessarily find, any imaging or other types of abnormalities. So it's been a very frustrating and I guess kind of insidious virus in many ways.
And which is why I won the $20 bet with my husband. Dr. Gutierrez, what was surprising to you?
We're learning something every day still about what's coming out with the virus. And, there's still so much to learn and to learn from each other. I really have enjoyed all the sharing of information between institutions. So that's been something that's great. Not that that's surprising, but wonderful that things are changing and that people have been so open about, publishing things and cross collaboration. But I think I had said it before that, everyone's patients are presenting differently. We, don't know about how it's going to end for them. And then that we're just trying to use the knowledge that we have to take care of them in the best way that we possibly can. And everyone's trying their best to do that in the medical field right now.
Absolutely. You guys are amazing. Do we have any sense of what percentage of symptomatic patients are likely to become these long haulers?
It's just every study is kind of different that looks at it. And it's, if you just look at a study of patients who are having symptoms, then yes, they're going to say it's 100%. But, is it a third? Is it a half? Is it 2/3? It's hard to truly know the numbers right now.
And have there been any observations of asymptomatic patients then that when you look at them, they come in for any of these odd sequelae that are happening in these populations, and then you do an antibody test and see that perhaps they had it and they just never had symptoms?
There is some that you're saying that, okay, maybe their symptoms weren't that much, or they knew a family member had it and then they had an antibody test that was positive. Or they just got a test anyways, and then a little bit down the line, they may be having some kind of symptoms. Or I'll have someone that didn't have major symptoms at all, and then 2 months later get a blood clot. So there's still something that's kind of brewing in their system that's causing these vascular sequelae. We've seen nerve injuries, we've seen Guillain-Barré type pictures, even 1 month, 2 months, even after the patient got over COVID, then something that's related occurs. So,
and that's something I think one of the questions from one of the attendees is, how has COVID-19 changed the recovery tactics for future pandemics? And I'd love to hear from all three of you on that, as well as what we think we may need to do with our healthcare system to prepare for what will obviously be a large patient population over the next 5 years who are having some of these long-term recovery issues. So Dr. Gutierrez, since you're up on the screen, would you like to take that first, and then we'll go through with our other two panelists as well?
I think now we have preparation. Well, first, I'm thankful to places like New York that kind of, had to go through this before we did. So we learned a lot of information, both from the acute medical side, but also the post-rehab side. I think now, just knowing what we know, and also that flu season starting right now, we're kind of worried, is there going to be another combination of flu and COVID and patients getting ill from that? And, is this going to be our third wave because of that? So with that, we are doing reboot teams, or just, kind of preparing reboot teams in case there is another surge. And from the acute side to the, what can we do from a rehab perspective, especially early ICU mobility, and then getting these patients to the appropriate disposition. And then again, collecting data on what's happening to these patients long-term and with the sequela. Believe it or not, when I talk to the post-COVID clinics in New York, they're seeing fewer and fewer of these patients. So that's good, that, okay, maybe the symptoms are bad in the first 3 or 4 months, but maybe by the time it's 6 months, it's not as bad, that they're not having to, just keep super busy COVID clinics. We'll see. Time will tell.
I will tell. Dr. Gupta, your thoughts on that?
Yeah, so I think that was a great response. How has it changed the recovery tactics for future pandemics? I think sometimes that clarity comes from once you're on the other side of it, and then you can kind of reassess and re-strategize for the next time. And I don't know when exactly that will be, but I think in everything that I've heard today and also from other colleagues around the country, it's clear that we need to be able to mobilize interdisciplinary teams for data collection, for assessment, all the way through therapeutics. And the more accessible we can make that, the better. You know, a lot of our resources continue to be focused on the sickest of the sick and the hospitalized patients, but it's been mentioned already a few times today that most of these individuals never come into the hospital. So it's equally important that those individuals receive the same information, same assessment, and same treatment in the future.
And do you see some of those same long-term sequelae with those patients that were in the hospital, those sickest patients in the hospital? Do they seem to resolve the disease, or are they just, because they're already in the hospital, they get, you know, they perhaps get, you know, a different type of care or something?
That's a really interesting question. I see both. I see. And it's a little bit early to tell because we're still only really 6 months out from that initial peak, but I definitely see, I have kept in touch with outpatients who have kind of been on that more well and more recovered end of the spectrum, and also those who continue to face a lot of debility and continue to need to access healthcare a lot.
Yeah, well, I will certainly tell you that preparing for this panel gave me a lot of things that I hadn't known I should be worrying about. Dr. Boom, as the head of an entire hospital system, what are your thoughts kind of globally with our kind of that entire healthcare system to be prepared for the next pandemic, which we know will be coming?
I think there's two pieces. Let me take a little twist on that first, which is, you know, as we move into this recovery phase, and of course, we all don't know yet whether we're going to have yet another surge. We certainly, as others are, continue to prepare with the assumption that, you know, we will have a bad time as the fall comes in, cooler weather comes in, et cetera, et cetera. But of course, none of us have a crystal ball and know that. But putting that aside, COVID has changed the healthcare system probably pretty profoundly, and I think consistently for quite some time. We're going to see whether it's just economic, access to insurance, other issues. Obviously, we've seen marked disparities from a socioeconomic standpoint. We're going to actually see probably pretty significant shifts in medical care that is occurring, which is good news, bad news. It's going to be a challenge for the institutions. Obviously, we don't want people to be missing care they need. But the flip side is, as we have to think about caring for a chronic population with COVID, staging up multidisciplinary clinics or virtual clinics and everything else, there may be some balancing that happens there in terms of how we allocate people and resources. And, you know, a cardiologist's time may end up being spent now, instead of, you know, doing something more traditional, now they're going to do a little more COVID care as they see some of the vascular, you know, or cardiac side effects of COVID, et cetera. From a pandemic readiness standpoint, I agree, you know, we're not quite at the point of you know, time point of kind of dust settled, now let's really take a look. But I think there's a few key themes. I mean, you know, no question, from a scientific basis, we need to think about how we are better prepared, particularly in the vaccination front, in the antiviral front. You know, we're a little bit lucky, frankly, that remdesivir was sitting on the shelf, tried for some other diseases, so it was ready to go and be used. And, you know, looks like it's modestly effective, but not dramatically effective. But we don't have a litany of other antivirals sort of sitting ready to go in a situation like this. We've not sat there and said, okay, there's a category of viruses we know tend to jump from animals into man, coronaviruses, but of course there will be other examples of that. What do we do to think about, is there a way to, you know, have a universal vaccine on the shelf, or a vaccine that would have some cross-reactivity on the shelf, or antivirals that work in those categories? So we really need to think about amping up the funding support, the research through the NIH, et cetera, of, you know, future potential pandemic readiness, because ultimately treatments and vaccines are going to be the major issue. From an operational standpoint, many other things. One is, I think we've all seen that from a hospital perspective, we've all done this, we've all had to do this economically, this idea of just-in-time capacity, whether that is, you know, capacity, or whether that is looking at things like PPE, we really need to rethink some of those issues. There's a lot of cost associated with that. It costs a lot of money to stockpile PPE, for instance, that may go bad over time. It costs a lot of money to have some excess capacity in place that can be pulled on. The HIDU, the highly infectious disease unit I talked about, was a small example of that, but one that was highly effective. But we made a multi-million-dollar commitment several years ago with Ebola that we could turn on pretty quickly now. In an ideal world, we'd have had even more capacity for that. Clearly, we have seen that our public health infrastructure is in dire need of work around the country, and that is at every level: federal, state, local, city, county, where we've been underinvested, under-resourced, and we've paid the price. A lot of that starts with the CDC. We should have a CDC that's been leading the way throughout all of this. My goodness, it's supposed to be the place internationally that heads up disease prevention and control. I mean, that's what it's about, and a lot of that's a resource issue. So we have to rethink how we resource, and there's many other things, but those would be a few that I would talk about now.
I think that's something that I think we can all agree on, is that this particular pandemic has exposed so many flaws and areas for improvement in our healthcare system. I think the other one is the testing strategy, and just really not having a kind of a really robust way to get testing out into the communities. And there'll be places where testing is overused and tested where it's underused. But kind of just one last question, you mentioned it, Dr. Boom, about remdesivir. What more can we do in order to have things for those folks with moderate illness? This is probably our last question that we have time for. So, again, thinking for all three of you, I'd love to know your thoughts on what should patients who aren't being admitted to the hospital, how can we better support them, and what is in the pipeline for potential treatments for that group?
I'll take a couple since you mentioned my name first, but I'll be brief. That is a big challenge, right? Most of the studies have focused on caring for more severely ill, even when, frankly, what the data has begun to show, whether it's convalescent plasma, even remdesivir, for most of the treatments that have some promise, it's probably earlier is better. We don't know how much earlier is better, with the notable exception of probably the best data-driven therapy from a drug perspective, which is steroids, and that's been now well studied, and that of course is on the later end of the spectrum, and that's really the best evidence we have around anything. We just simply don't have the rest. There are others being studied. There's a drug called favipiravir, which is kind of in the family of remdesivir. The beauty of it is that it's oral, whereas remdesivir is intravenous. So if it were to work anything like remdesivir, it could be a Tamiflu type analog. Now, Tamiflu is not a wonder drug. Tamiflu, prevents a little bit of flu and certainly can be used preventively in family members. It shortens duration and severity, prevents sometimes people from deteriorating, but it's hardly a wonder drug. But even that, if we had the analog for COVID, could change things a great deal. I think it's going to be very interesting to see what happens with the monoclonal antibody trials that are underway. We're doing some of those. I'm sure all of the institutions mentioned here probably are in some of those trials, because those take the next logical step of convalescent plasma and now give these specific antibodies in high titer to individuals. Again, is that going to be early? Is it going to be late? It's probably early, I think most people would guess, but we just don't know. Those are a couple of the major impacts. But quite honestly, my take is most likely we'll see a vaccine have a big impact before we'll see some sort of game-changing medication have a big impact on this pandemic. Yeah. We just had some bad news out of AstraZeneca today with a patient with transverse myelitis that they've halted the trial while the data and safety monitoring board's taking a look at that. So that's hardly good news. It happens all the time in studies like this, but it's not what we wanted to see. So we'll have to see some dust settling on that too. Let's hope that doesn't pause things too much.
Dr. Gutierrez, your thoughts on that?
So I think, a lot of the research dollars have been put on what's everything that's done initially for the patients who are hospitalized, who are critically ill. I mean, I'm thankful for that. We in San Antonio had the most patients in the world in the remdesivir trial from all other sites. So it was nice that we got to do that and, you know, see the outcome of those patients at our hospital system. But now that we have to say, okay, what about the ones who are at home? What can we do for them? I think we don't, you know, again, have that magic bullet yet, nor do we have tons of research dollars going into that. So we're just treating patients as they come symptomatically, just depending on what symptoms they have and based on what we know how to treat other similar disease states. And we're just treating them that way. And there's not a magic pill yet. We just have to, you know, look at the patients individually and help them with the issues that they have. But like you said, you know, sometimes still feeling shortness of breath, we do pulmonary function tests, or they may have, you know, a cardiac exam, and those all be normal and still be feeling terrible. And so time will tell, and right, we need a vaccine. Who knows when that's going to happen?
Dr. Gupta?
Yeah, I would agree with both. I think right now we just don't have a treatment strategy for outpatients. Intuitively, my best guess would also be to agree that a vaccine will prove to be more effective early than another treatment, but I have no idea. I mean, what we have right now is population-based strategies and risk scores that help us stratify people into different tiers of risk for severe illness, and that's basically what we're operating on. And we do that based on somebody's history, including chronic illnesses such as cancer, autoimmune illnesses, and many other things like diabetes and hypertension, and also based on the severity at the time of presentation. And it's also important to think about it the other way when we do get to a treatment, like how does a potential treatment strategy impact recovery from COVID-19, but also the other way around. How does any treatment also impact a chronic illness? And I think that's still a big question out there. But I'm hopeful that we'll have some strategy relatively soon.
Well, and we just, I'm in awe of how far we've come from a scientific perspective in such a short time. I think, you know, we've all touched on that the way that the scientific and clinical community have come together and shared information and shared reports so we can make the best decisions we can. I want to thank all of the panelists for joining us today and sharing their information. I know I learned an enormous amount, and I hope all the attendees did. With that, I'd like to turn it back over to Terrence to wrap things up.
Thanks, Dr. Aldridge, and thank you to all of our speakers today. That was definitely a very informative session, and I think is a good reminder that we have so much left to learn about this disease and about how we can improve our healthcare system in the future. So I hope someday in the future, as our knowledge increases, we can bring this group back and see where the science has gone. And
maybe
want to just, sorry?
Maybe even in person.
Maybe even in person. That would be an even better way to do it. We'll definitely look forward to that day. So thank you again for taking the time to be here with us today and to share the science with our research community here in Texas. For those of you that would like to watch this session later, we're going to have it up on our YouTube page, and we'll send you a link to the video. We also have this and all of our other past sessions in our Forward Texas series on COVID-19 archived on our website, which is TAMEST.org. You'll be receiving a survey after this window closes in Zoom, and if you have some time to provide us some feedback on this session, as well as give us your thoughts on other topics that TAMEST could convene on that would be helpful to you and to our scientific community. We'd like to go ahead and preview our next session, which we're really excited about in this series. It's going to take place in about a month on October 7th, and it's going to focus on healthcare architecture and facility design in the age of COVID and in light of new infectious diseases. So our moderator for that session is actually a member of our conference planning committee, Ray Pentecost from Texas A&M University. And we've got a group of architects and design experts that are going to talk to us about some of the immediate responses that took place in healthcare facilities in regards to COVID-19, as well as some lessons that have already been learned about how to either retrofit or newly designed facilities to better treat and take care of patients during COVID-19 as well as future infectious diseases. So we're really looking forward to that session and hope all of you will join us for that. There will be a link to RSVP for that session in a follow-up email that you'll receive tomorrow, along with the video of today's session as well as the slides. With that, we're at the end of the hour. We really thank you for taking the time to be with us today. And once again, we'd like to thank our moderator and our 3 speakers for sharing the science with us. We hope all of you will take care and be well, and we'll see you next time. That concludes our session for today. Thank you very much.